everybody on the webinar. Thank you for being here. And I feel very honored to kick off your society. And it's a typical Dutch way to do that with presenting some flowers and some champagne. So I wish you all the luck in the world, and cheers to a great society.
Thank you, Peter. Thank you very much.
So yeah, I was asked to deliver a talk, and Ignacio and Pedro, we had some conversations, and I know we have limited time, but yeah, I would like to dive directly deep and just bring the essentials, what I believe, what I learned over time is going to be very important to consider, at least before you start. These are my disclosures that were currently nicely presented. And actually, I want your brain to be empty. I would like to know, or maybe whatever you know about PRP, just put it in a little side hole of your brain and open up your brain maybe for some new stuff, which we believe will make a difference in time. And I'm telling that because I had a long ride on, what I call my personal coaster. So this is just an impression from a roller coaster with highs and with lows, and I would like to share with you where I got started. So I started my career in regenerative medicine in 1989 in open heart surgery. That's for the first time we started to use PRP, and from there on we moved to orthopedic surgery, to wound care very quickly, and that was an interesting period thereafter. We already started to publish with some great results. And actually, we started to think about, well, why don't we take it more serious and move into, some more research. So I was lucky enough to be exposed to animal work, did quite some animal studies, but also, as you can see here, there was a first, hybrid procedure. So where we use orthopedic surgery, and we almost finished the procedure by the application of PRP. Then in 2007, I was able to defend my thesis, and from there on, I collected everything I could. From a biological perspective, I had a significant interest in hyperbaric medicine, and I was one of the first to make the combination between hyperbaric medicine and biological therapies. Another high was this paper we published. It was, and still is, one of the most highly cited papers on PRP. I was asked to become a professor at Unimax. I did some interesting lectures. And now I'm very honored to be invited to speak to you from the Spanish Academy. What I noticed over time is to build connections. And building connections would mean try to find your peers, try to find people that you trust, try to find people with whom you can have a, conversation that would make sense to what your goals are, where you would like to do. And I found that for many, many years ago in my dear friend Luga Podesta. So this is a picture at his office. And that always created lots of stimulation and discussions as well. Where do we need to go? Are we on the right track? So now I'll take you on a helicopter flight to go over some details which are going to be important. So you've seen Pedro already and Ignacio kicking off. And I think what we need to address is, where will the field of autobiology be in 2025? So what's going to happen in time over the next couple of years to come? But before we do that, we need to understand as where we are right now. In order to do so, I prepared this agenda. I would like to discuss with you is, where are we? How is autobiology positioned in healthcare? Just spend a couple minutes on the platelet secretome, what it really entails. And then it's going to get more, complicated, because it's not always clear what people's goals are when they start with PRP therapies. We touch for 30 seconds on indications, and then it starts to become more interesting, I guess, because we need to understand when certain PRP therapies do not give the success for your patients. and what's the basis for that? And then I would like to touch on some new things that we discovered as well. So let's try to figure out how's healthcare defined right now. So what we all know is the healthcare options for patients is surgical procedures or surgical manipulations with a lot of different surgical techniques, as well as medicine, drugs that can be prescribed to patients, and there are also different variations. But I think listening and looking and observing the literature, I think the use of autologous biological products is making a lot of wake and is making a great a great forum, so to speak, for patient treatments. And they are actually biological medicine uniquely positioned because these are what we call interventional therapies. And most often, and that's what we see also in the field of indications, the use of non-surgical biological therapies are often positioned to treat patients who are no candidate for surgery or in whom drugs are really failing. And of course, there are a lot of regulations with it, where well, we need to be compliant of. First of all, it needs to be safe. Whenever you start these therapies, safe. I'm a big proponent of autologous products or patients' own products. There's something to consider about regulatory compliance, but then it really gets interesting is how do we going to deliver it? We can make this a personal experience for patients. We can make this a very personal therapy, more than anything else. But we need to keep track on what we're doing. We need to, well, maybe even go back to our university and find the textbooks, because when I speak with physicians, there is a lack in knowledge on how biologics work. There's a lack in knowledge about the synergy of biologics. But we know for one thing for sure, we have a huge potential there. But reviewing the literature, and I'll show that to you a little later, is also that most often we do not speak the same language. Most often we cannot connect the data that have been shown by research and how to translate those scientific data into clinical practice. In a lot of cases, that's not possible. And then, well, can we accept outcome of real data? Can we accept the outcomes of studies? And are we willing to implement those in our practices? Because we still are far away from any consensus in, well, the definition of orthobiological preparations, how to do it, what are treatments goals, and well, the field of application continues to grow. And then you have these simple discussions. No, I'll do it always my way. And your way, I mean, ultimately, ideally, we should find consensus and we should make it our way, right? Because the patient is, well, the biggest portion here in order to make things really, really work. So let's have a look. This is my pot of soup with all the cells in there, right? And for now, I would like to, well, make 3 dishes for my biological use. And the first one would be the use of PRP, and the other 2 plates going to be filled with mesenchymal stem cells. And that's where we are, and that is what the patient is owing. So the patient owns the entire soup, and we just have access to it in order to make biological therapies really work. And for now, we can talk hours and hours about everything of this, but let's focus on how we can make our recipes work, or peer-to-peer recipes work, in this case, to the best interest of patients. So the platelet secretome, very quickly, what is it? As we sit and listen, nothing is happening with platelets. They are circulating in the bloodstream in an inactive way. There happens to become some kind of a trigger, and all of a sudden the platelets become activated. And activated, the definition of activation would be development of so-called pseudopods, where they grab each other and where they form a a platelet block. The next step is the release of their granular content. So their granular content, whether it's growth factors, cytokines, chemokines, they are all being released from the platelets. And the next step will be, and that's how we think that PRP works, is that the individual growth factors will find their dedicated cell membrane receptor and they connect. And when they make the connection, that's where the intracellular signaling starts to occur. So there are many cell membrane receptors, each for them with a different growth factor connecting to them. And when we then even look further and we see what's in there, then we recognize, and this was a study we did a while ago on electron microscopic activities, looking at how are these granules organized? Is it one granule? Is it multiple granules? What else is in there? And then we recognize, of course, the alpha granules with all the various platelet growth factors in it. And then the list only continues because there are so many more factors in platelets, and we really should and can consider platelets to be the directors of our healing cascades with all their chemokines and immune modulatory molecules in there. And then after activation, there's a big difference in aspect, right? So you see the platelets here fully intact, and after activation, the only thing that's left is a cell membrane, and platelets have been completely empty. As a bonus, that's what I call it, as a bonus for using PRP therapies, there are a lot of additional structures and PRP effects to be anticipated. So that's simply based on what's all together inside platelets. And that's a huge thing. So all the cells in there, they contribute ultimately to the onset of healing or reparative of regenerative cascades way more than the platelet growth factors. So what's essential here, the first message is understand the dynamics of the platelet secretome and acknowledge how many growth factors and biomolecules we have. And if we understand that, we ultimately can go to the next step, and that is, well, to make these PRP for us more workable. And I'll show you that here. What do we need to consider? Well, first of all, be aware on the whole blood constituents and how we can concentrate those, or in some cases we cannot concentrate them depending on your techniques. But anyway, you have access to the patient's own blood. You choose your devices to work with, you choose your protocols to prepare PRP, and then you have a biological product which can be used for specific PRP therapy goals. And tissue regeneration repair, we understand it for years. Immune modulation, that we do have a chance when working with these PRP constituents that we're able to control inflammation. I'll show you a little later on angiogenesis and what we discovered some 20 years ago, the analgesic effects. So all of a sudden, PRP therapies will find a dedicated place in pain management. And ultimately, the goal would be in traumatized tissues to, restore function, restore functionality. And one way to do it is to work with, different PRP formulations. And one way to do it is, keep in mind, whatever you want to do, that it is, the ability to concentrate cells, the ability to choose, one cell over the other a little bit more, and then you can apply those in non-surgical procedures and in biosurgical procedures, so the indications are going to be tremendous. That's one thing we should not forget, however, that any PRP that we need to have ready to deliver to patients should be based on patients' characteristics and should be based on what is it I want to treat. So what's the pathoanatomic condition? A tendon tear is different than a meniscus tear, and a osteoarthritic condition is different than the tendon tear. So we need to distinguish way more, and then we get to the discussion which already started. Is leukocyte-rich versus leukocyte-poor PRP. And for some reason, somebody came up with the fact that leukocyte-poor is preferred over leukocyte-rich. I'm still trying to figure out who that was and what these objectives really are. So based on the fact, what we learned over time, making different PRP formulations, we published these two papers, and I will address both of them a little bit more in depth. But what we see is that we can actually manipulate our PRP composition. I'll show you why. So this would be an image of what we call the buffy coat layer. And the buffy coat layer has a lot of cells in there. It has platelets and all the white blood cells in there. And up to a certain point of cells collecting in the buffy coat layer, we can produce a neutrophil-poor PRP. Or we can make a leukocyte-rich PRP. And you already see the differences between the two of them. That's all based on the density separation of your whole blood. In other words, all of these cells that you see here, they have a different density. And it's pretty sure what the limits of density are for monocyte, lymphocytes, neutrophils, and RBCs. But what you maybe do not know is that the density from platelets ranges tremendously. So depending on, well, what patient, what the condition of the patient, or what the medical condition is, the range of the platelets might vary based on the density of the moment. So in other words, you should be able to make, ideally, with the choice of your PRP device, a neutrophil-poor product or a neutrophil-rich product, or, as we will demonstrate, a combination of the two of them based on what it is that you would like to treat. And then, of course, well, the battle is on. I mean, when we started to publish the first paper, people almost thought that we were crazy, that we were, well, reinstituting discussions about the neutrophils. So we are working on a couple of papers right now on demonstrating the efficacy of neutrophils as part of your PRP formulation. So what's essential as well to keep here is, before you start any PRP protocol, have a game plan. Know exactly what it is you want to do. You do not want to tell your medical assistant, oh, you know what, I still need to do maybe the meniscus as well. So you know what, give me a little bit more. So the blood was taken, the PRP was prepared, and then all of a sudden the physician tells your medical assistant, you know, instead of 6, give me 9. And one way to do it is, of course, add the PPP to it. And you have a volume of 9, but keep in mind, anything you do on a volume basis has a consequence for the concentration and has a consequence for the total delivery of platelets that you need to do. So in other words, define your goals and your needs. And based on that, you really decide what your strategies are going to be. Indications I mentioned already very quickly. Let's have a close, quick look at it. It all started with, well, cardiothoracic surgery, chronic wounds, orthopedics, and from there on, you can follow the list yourself. And now we are looking very actively in infertility and urology. So we are not there by any means, and the number of indications is rising on a continuous basis. And even when we stick into sports medicine or orthopedic indications, for each of these joints or tissue or MSK structures, we can come up with a lot of different indications where PRP has been used. But at the same time, that's now where the trouble really starts. So the more we do, the more what we see is there's not one PRP product. There are PRP-like products, because the definition of PRP is platelet rich plasma, plasma that is rich in platelets. Anything else, and I think it's fair to say at this stage, where we do have, well, maybe a limited consensus, is that should be at least 1 billion platelets per milliliter. That's more or less what's being accepted and being touted. And then please be not surprised if that will go from 1 billion to 1.5 billion. But anyway, we need to understand that if we have a non-controlled environment on, well, what products are effective, what products are not effective, we create a lot of confusion and outcomes. We create a lot of confusion on, well, the expectations for patients as well. Because the market, the PRP and stem cell market has gone completely nuts. Because there is no rule in place, as long as the device is safe, that it is measured by efficacy. I can show you a bunch of articles, and I'm pretty sure you've seen them as well, where it did not make any difference when PRP was used. And that's simply, well, only the beginning. And there are dozens and dozens of papers published that PRP doesn't work in these cases. And when you then look at, well, what has been published on efficacy of devices, on platelet capture rate, on total deliverable platelets, then we also have these papers available. So these papers really indicate, give you good guidance on, well, are we talking about the same definition of PRP? Is it maybe a different kind of product? So keep in mind, when you do your research, when you look at, well, what kind of product you would like to use, just keep in mind that that's going to be a very, well, very rough ride to go in order to make that happen. But the most important thing, I believe, is not the device that you can use, because you can have very modern devices, because simply the territory where you are has access, patients want to pay for it, but you also have very simple devices with similar centrifuges, but you still can make a good quality PRP. It's more time demanding, it needs more commitment, but again, based on, well, your objectives and what you want to treat, with simple and complicated devices, you can make, well, different bioformulations. And what ultimately makes the difference is you, because your biological mindset, how you want to prepare PRP, that makes a difference for your patients. Are you going to be meticulous? Do you know exactly what you want to have? And there is supportive literature out there to indicate to you the differences between PRP and PRP-like devices on the market and how they might affect it. We did a proteomic analysis a couple of years ago, looking on the differences and the commonality between PRP and plasma-based devices. And it's not a surprise. It's not a surprise at all that there are huge differences. And these different differences is not because one company tells I have a better product than the other. No, it's simply based on the results. And even within the same device, the flexibility that you can have is going to be huge. Same here, same device. We use three different formulations. We produce a pure PRP, a leukocyte poor, and a leukocyte rich PRP. And then, well, we try to measure, and we did measure that, what the impact is on the final dose of PRP. So when you look here, well, what we see is that the total available platelets range dramatically. So for example, let me go back one here. Pure PRP, 7.1 billion platelets, 10 billion platelets, and almost 12 billion platelets. That's how the dose, the available platelets, really changes by employing different preparation protocols within the same device. So based on your goals, based on what tissue types you would like to treat, ideally, you should have a product that's capable of producing different kind of PRPs. But keep in mind, you never can have more platelets in your prepared product than your baseline. And sometimes when I review papers, the baseline platelets available in the patient's blood is less than what is in the final PRP product. So I'm still looking for the answer how that's going to work. But be critical on the fact that when you start to work and start to develop an interest in dosing and in volumes, that well, you need to be very meticulous on the volumes. And from there on, what we notice is as well the impact it has on the other cells, especially on the neutrophils and the monocytes, based on, well, what kind of product and what kind of protocol you would like to work with from a dosing perspective. And that's then where, well, we play in with the needs for the individual patients. Do we want to have neutrophils? Do we want a slight amount of neutrophils? I don't want any neutrophils, so I have less platelets. So anything else is open for preparation. But the big message here is one size does not fit all. When we think that any PRP is going to do the job in the same way, that's simply not true. And we reviewed a lot of papers. So what we did is we were looking at, well, different dose response curves, where we said, hey, listen, we need to understand what it is that certain therapies are successful, whether it was spine or tendon ligaments. And we related everything for as much as it was possible in the literature to, well, to the volumes that have been used, to the capture rate of the device, PRP volume and concentration. And that's how we started to understand that for each of different pathological conditions, we have a different kind of, well, needs for dosing. And actually, that's why we came up with, well, with this article, what is it, yeah, close to 2 years ago, where, well, we understood that, well, we need to be successful only if we have, well, sufficient load of healing cells available. So what's essential here as well, do not believe any of these sales representatives that get to your office. Do not believe that they tell you the truth about what kind of PRP their device can make. The only way to do it is validate yourself with people in your own department, with a laboratory close by, and then choose your PRP product based on facts. And then it's going to be way easier to implement biological formulations and do treatments based on pathoanatomic situations. Because when you look at it, everything that's going to be involved with healing, it starts with platelets. So the platelets is actually, well, the first cell in any, well, traumatized area there we would like to have reparative processes started. And the platelets really connect very well with all the cells that are in its environment, in that local microenvironment, in order to jumpstart the healing process. And this is just a simple slide. That's when you cut your finger, what's going to happen. So platelets are normally not activated. You start to bleed. The disruption of blood vessels, a lot of cytokines are released. They activate platelets. They throw out their content. And that's where the healing cascade really starts with the platelet. And from there on, any of these cells are involved ultimately in the healing before you get to a completely healed wound. So that's where we need to look into. But if we have a deeper look, if we look under a microscope, what it is that really makes a difference more specifically, then is angiogenesis. We need to understand why it is that certain tissues heal or do not heal. And when you look at the angiogenetic cascade of healing, which we never discuss, which you will not find in any of the textbooks related to autobiological preparations, the angiogenesis cascade is playing a very profound role. And what you see here all is that, especially in the amplification phase and further on in how to stabilize the new built blood vessels, platelets and platelet constituents play key roles in order to reestablish vasculature that has been diminished because of, well, chronic inflammation, for example. So it's fair to conclude that angiogenesis is vitally important in regenerative medicine applications. And it's a combination of angiogenic growth factors, which are in platelets, which are in platelet-poor plasma, which are in white blood cells, and how they work with receptor cells in the area. I'll show you this example from one of my earliest wound care patients. A young boy, severe diabetic, had wounds, amputated fingers, And with the introduction of PRP, we released a lot of growth factors, a lot of cytokines, chemokines, and that all together was able to rebuild blood vessels in places where they really need to run, and that's very important. So we need more angiogenesis when we would like to accomplish healing, especially in chronic tissues or in senescent tissues, right? And areas with poor vascularity. Think about tendons and ligaments. These areas are not known for their vascularity, and therefore it's pretty short to understand what is it, how can we stimulate, how can we reinstitute blood vessels where they used to run before any degenerative tissue was built or trauma was built. And that's where the platelets really play a key role. And not only the platelets, because if you look into it, what's the presence of all of these pro and anti-angiogenic factors? That's both, and that's both in platelets, but also in white blood cells. So there is a lot of common sense that if we would like to reinstitute angiogenesis, rebuild the blood vessels, that we need to think as well on the presence of, other cells than the platelets. And we explained it more in detail. We don't have the time to do it now, but if you want to have access to the paper and you can't get it, let me know. It should be open access, so you should have an ability to read it. And there is supportive literature enough to indicate how important angiogenesis is, especially in an area with deprived vascularity, and how important it is, because we need to restore it. We need to restore the blood vessels, because otherwise we won't get oxygen in there. We will have no way to eliminate the waste products. So it's going to be critically important in order to have a positive patient outcomes in areas with poor vascularity to first of all consider how we can reinstitute blood vessels. And this is another paper. It really indicated that, leukocyte-rich plasma, PRP, is the way to move forward. And it had a considerable effect on pain and pain relief, as in tendon repair as well. So that's where I feel we might be very positive on using, the acceptance that leukocyte-rich PRP contributes to better healing in areas with poor revascularization. And again, I mentioned earlier too, we still have a lot of negative articles that we need to come up with. And in order to get rid of those, negative patient outcomes, we need to understand absolutely, can all these devices facilitate tissue repair, tissue regeneration, based on, their capabilities. And I think it's only, fair to be speculative here that, a lot of these devices cannot do it. A lot of these devices are not able to reinstitute blood vessels, create angiogenesis, simply because they miss their efficient pro-angiogenic factors in sufficient concentrations in there. So that's why I'm pretty sure, and all these papers, when you analyze them, and that's part of the publication we did as well, is they do not all contribute to angiogenesis. There's more going on. So what's essential? Essential is angiogenesis. Restore blood vessels that have been destroyed based on chronicity, mainly. Create a PRP that will be able to reinstitute these blood vessels. And for now, the leukocyte-rich PRP is in favor to induce, in a relative, fast way, the reintroduction of blood vessels. So now let me show you. Let me show you a case report. You see me in the chair. You see Dr. Luga Podesta holding this syringe. These were my pathologies based on MRI findings. And we sat down and said, listen, these are all different kind of tissue structures. They all have different functions, and they're all part of, well, one organ, right? And that organ was my knee. And we just want to create a procedure that's going to meet all of these pathologies here. And that's why, based on the pathologies, we created diverse PRP formulations. And with that said, is we made both leukocyte-rich and leukocyte-poor PRP. We took my blood, measured how many platelets were available. You can calculate, and I'm more than happy to share that with you. You can calculate what it is.
Esto? No lo sé. ¿Cómo se quita la puta cámara?
Hello. So what we then did is, well, based on the baseline, we took 120 cc's of blood, and we made leukocyte poor and leukocyte rich. And this is how we distributed it. We had the first syringe leukocyte poor, and then we had 3 syringes of neutrophil rich PRP, leukocyte rich PRP. You see the numbers here. We knew exactly the dose that we would like to have. And the dose here was based on the literature. So people keep asking me, how did you know what kind of PRP you would like to have at what dose? So, well, listen, by reviewing the literature, which I showed you the picture as earlier on, we knew exactly where, well, the limits are for a successful outcome and a non-successful outcome. And anywhere from osteoarthritis, I think it's fair to state from what we know right now that those should anywhere between 7 to 10 billion platelets. And for tendons and menisci as well, you can look it up where the failures were reported. So based on the amount of volume Dr. Podesta wanted to inject, based on the concentration in my blood, knowing the capture rate of the device, we were able to make this a very personalized experience in doing the injections. And that's how we said, listen, let's publish it. Let's get our philosophy as why we did it. Let's get it out there, and let's demonstrate exactly that it is possible to do a procedure with a different kind of biologics, with different kind of formulations. And again, so we had the 4 syringes, and they were all, well, accurately delivered to the pathological sites. And well, from there on, well, the repair process started. And this is, well, an ultrasound 11 months after. And the middle one here was taken 12 weeks after. So you already could see, well, after 12 weeks, the healing, well, was started. And then we did another follow-up ultrasound later. So the meniscus tear was gone. There was a way better organization of the MCL ligament. So back to normal, with normal functioning and no pain. And the only thing I did, which I strongly can advocate, is make sure, tell your patients to do a maintenance dose. I mean, osteoarthritis is not something you're going to cure with PRP. You can, well, bring it down. You can become very active, but in order to well, to stay away from complaints and pain, you need to have, similar with any other chronic disease like diabetes, you need to have your dose maintained. And that's what I've done 7 months ago. Have a maintenance dose only intraarticular, and ready to go. So essential here is variable processing, use different kind of PRP, different kind of volumes before, well, before you do your treatment. Now, Luga and I, we've been working on the project and understanding more, and this is going to be the last part of my lecture. We have been working on something else, and I'm not quite sure how many of you in your current practice really incorporate the patient, but then from a homeostatic perspective. In other words, what's happening with the patient if a patient has osteoarthritis? What's happening with the patient when, well, there is another inflammatory condition, acute or chronic? And how does it impact our PRP? How does it impact outcomes? Let me show you. This is a great paper from my friends at Harvard University, looking at tissue homeostasis and inflammation, right? And what's going to be important is to understand how the individual patient how the individual patient's brain and nerve system works and has an impact on PRP production. So homeostasis regulation has been, has been nicely published in different journals, really indicating how it works from a MSK perspective and what the goals are if, well, a signaling occurs, which I'll show you in a minute, and what it's trying to accomplish. Same here. Let me show you in this little example. This is a condition where, well, due to chronic inflammation, as you can see, the blood vessels have almost diminished. And that really, well, incites a lot of activities from cells you do not want to have in your joint or in your tissues. So the body recognizes that based on a diminishing angiogenetic pathways, that the oxygen in the area is going to be decreased. So there's going to be signaling based on decreased oxygen content. And that really incites what we call a local tissue hemostatic response. And by looking at, well, how hemostasis works, which we're not going to do right here, resident macrophage phenotypes who detect the low levels, they start to secrete VEGF. They will signal to endothelial cells in order to reestablish blood vessels. So they try to maintain an optimal environment. And that's why leukocyte-rich PRP is very supportive in repairing angiogenesis, because it adds the value to, well, any homeostatic process that the patient already incited. So maybe you know about the human to brain axis. We got the brain to gut axis, right? And we got the brain-bone axis. Maybe that's not as important or not as familiar, and the same the gut-to-bone axis. Those are the three axes that we work on. Now, what's even more important is how does the brain communicate with circulating PRP? What's the pathway, right? So let's try to build this slide. Your patient has osteoarthritis, and there are a lot of neurons signaling to the brain, hey, listen, something is going on. I feel pain. And that's being registered in the brain. And from there on, the brain-bone axis becomes involved, and the sympathetic nerve system starts to communicate from the brain to the bone. And then we finally get to the brain-bone blood triad, as it has been published about. So we see the brain is communicating with the bone, and what's happening in the bone, as we know it, the bone marrow cavity is releasing its content. It's releasing, in our case, what's important is neutrophils, lymphocytes, monocytes, and platelets. So all of a sudden, we see the platelets becoming on the forefront again with any of the other hematopoietic stem cell progenitor cells working together, because there was a stimulus from the patient's knee OA to the brain and setting up the communication between the brain, the bone, and the blood in order to have in the bloodstream, well, reparative cells. And this is what we call systemic level hemostasis. So we had a local one and a local microenvironment, very, very specific to a typical situation in that microenvironment. And this is all over. This is a systemic level hemostasis. But what's happening? The interesting part really starts now. So when you recognize that there is communication between the brain and the blood in order to, well, to get relief from a pathological condition. But what the bone is doing, the megakaryocytes, they just do not throw out platelets. No, they throw out platelets in different sizes. And what they try to do initially, when they recognize there's an inflammatory condition, they want to repair it, systemic level homeostasis. And they, through megakaryocytes, they throw out big platelets, huge platelets. And these platelets is what we call, well, the PRP quality effector. Because when you stick a needle in a patient, you will have platelets, but you do not know what kind of platelet it is. Is it a small one, an older one? Is it a very young, very fresh one? The only thing we know, and that has been demonstrated over and over again is bigger platelets have more alpha granules, and more alpha granules have more molecular reparative capacity. And again, it's not something we make up because we like it. No, it has been well published. The relationships between different white blood cells, the controlling role of platelets, and how they guide the responses from neurons to heal it, that's a very important pathway, and therefore it really can have an effect on your PRP and your platelets in there. And that's where we got Sparkle, and that's where we started to work with, well, let's measure. Let's see whether we can really get our finger behind, well, what kind of platelets are where in our PRP. So again, this is just to show you, and look at the date, 1984. Evidence that platelet density depends on the alpha granule content. What it really means is, with one of my earlier slides, we do not have the right textbooks. We do not have the textbooks that indicating how the variability is. But what's going to be interesting now is, okay, what's the relationship between treating osteoarthritis with particular PRP? This paper was published, and to a good surprise, they did a very nice laboratory analysis, and they compared the whole blood with PRP, and they looked at the size, the mean platelet volume. And what you see here is, in the whole blood, it was 10.6 vectoliter, and in PRP it was 10.1. What does it mean? That means that in the PRP, the size of the platelets was smaller than was circulating in the blood. So based on the choices these investigators made to treat knee OA, they had a formulation or a device, I don't care, where they were not able to get to collect the most dense platelets that has the highest reparative value. And the other thing is, those were neutrophil poor PRP preparations. And when we then understand this based on this gravity cellular density, where are these bigger platelets, then if you stick very high above that buffical layer, you will never have the more dense platelets. So that's another reason why we believe, well, we need to keep in mind that if we want to have, well, PRP that has a platelet value which is, well, at least competitive with what the patient from a homeostatic standpoint is producing, we need to have, well, the collection of these numbers. And you can't do that, right? So what does that really mean when we look into it, and how is the connection between PRP, the size, and the platelet density for tissue repair? And this was a very nice paper. It really laid it out very nicely. So there was when they did a correlation analysis, what they showed is that the level of VEGF was highly correlated with the size of the platelets. So in other words, if we have big platelets with many alpha granules, meaning a lot of vascular endothelial growth factor in there, that made a huge difference in their outcomes. Whereas when they looked at, well, the correlation between the numbers of platelet, the platelet concentration, that did not make a difference with regard to the presence of VEGF, right? So higher concentration of platelets did not affect the VEGF concentration, whereas the size, the density really did. So in other words, what we need to keep in mind is that for some reason, in a reparative state where the patient is, and we want to intervene, we at least should consider the fact, well, maybe the platelets I am giving to my patients might not be the same as what, well, the patient is trying to accomplish himself, based on the fact that the bone marrow itself is releasing bigger platelets in response to a pathology. So that's something that I think we should develop more, and we definitely will. So what's essential, we need to understand that PRP, the quality of PRP, can be affected by the connection between the brain and our tissues, and that there are local and systemic effects going on in tissue repair, and that the homeostatic response for a huge deal affects or platelet density. So I'm almost done. Take-home pearls. We need to reestablish our thinking about cells. We need to understand how the synergy between platelet-derived cells and any other cells, as the Lord gave us in the bone marrow and releases them on a continuous basis to the bloodstream, we need to understand these mechanisms. And we also need to understand why it is that you, want to have a manipulated PRP product by keeping these full yellow products available, right? So all of these reparative mechanisms that lead to tissue restoration, they can be accomplished. The only thing is, we need to have an eye open for what kind of PRP you would like to use, and consider the effect of adding a dosing strategy to your therapies. And nowadays, when you can do it with a biological mindset based on pathology, you really can characterize your PRP in order to make it work. So now, I think where we are today, we are actually at a good spot. We start to develop more knowledge on what's essential in PRP preparations in order to create consistent positive patients outcome. If you have any questions, this is my email address. Send me an email. If you request papers, I will send them to you. And I would like to thank the organizers, Pedro and Ignacio, for this opportunity. And I would like to show you my dear puppies here. Thank you so much, Pedro, Ignacio. I wish you all the best, and I look forward to any future collaboration. Thank you.
Wow, dear Peter, I am really impressive. Wow. I want to thank you for your effort and dedication to research, so meticulous about biological therapies. Your talks have been really spectacular, really. I think really everyone interested in orthobiology should study your recent articles that you show us, and of course, listen to this presentation. Breaks paradigms and opens new borders, I think. There really can't be a better good father to start these educational projects such as the Spanish Academia of Medicine Regenerative. Thank you very much. I would like to ask if any of the assistants have any question to Dr. Peter Everts.
Yes, I would like, I am Gonzalo Mora. I would like, first of all, thank you very much for the wonderful presentation. It's really key points, very valuable for our day job. So it's the way we can improve our results in our patients. But you mentioned about maintaining a dose. I mean, when you were treated on your own knee, you said that you try to maintain a dose a few months later. Is there a role or a special amount of time you decide when you go for another doses, or is when you start feeling a bit painful in your knee, or just 6 months later, 1 year later? What's your opinion about that?
Yeah, thank you for your question and your very nice comments, Dr. Mora. That's a good question. When you look at the literature for osteoarthritis, you find different believers and different streams. There are people who just want to treat their patient once. You have the patient, I want to treat him once with the proper dose, and the patient is going to be good for a lengthy period of time. And based on the work from Professor Banzal, that's close to 12 months. So with the proper dose, you're able to control the microenvironment with all the cytokines in the knee to keep them at a very low level of becoming more inflammable for up to 12 months. Then you have believers who say, no, I want to see my patient 3 times and inject the patient 3 times in 3 months. And the funny thing is, when you look at the results from the literature, that after the third injection, all of a sudden they do well. So in other words, the total amount of platelets that will make a difference in outcome for patients is dependent on, some kind of a dose, and that varies from 7 to 10 billion. I requested a booster or a maintenance dose based on the fact that, you know, you start to think, this is a little itchy and it's going to be a little worse, you know. For now, the acceptance of doing maintenance dosages is not solid. It's only based on, well, very incidental reports. And I've seen more and more, because we need to understand that PRP does not cure osteoarthritis. It just keeps everything down and slows it down and gets you back to where you are. So I would say, but maybe Dr. Podesta, as the one who did it to me, what his experience is, but anywhere from, I would say, from 8 to 14 months at the moment, based on the initial dose that was given, it would be fair to reconsider offer to your patients a maintenance dose to keep them away from, well, further deterioration. Dr. Podesta, what do you think?
I agree, Peter. In my own practice, I typically will wait for the patient to come back and tell me when their knee is starting to bother them. But I think it's a good idea, and I'll tell them when I initially see the patient prior to doing the procedure. The way I present it to them is I tell them I can get soft tissue to heal. I can get tendons to heal. I can get a ligament to heal. I can't get osteoarthritis to heal. And I present it as, you know, we can treat the soft tissue, that's a healing state. We can get that to occur in most cases. And osteoarthritis is like treating hypertension or diabetes. It's a maintenance. And that's how I present it to them, because I said at some point, you're going to do something, the load is going to be sufficient enough to re-aggravate that knee and trigger that inflammatory response again. And that's what I tell them to look for in the future. And that can be a year out, that could be 2 years out, sometimes that can be 3 years out, depending on the combination of tissues we treat and the grade of their osteoarthritis and their activity levels. Down in Naples here, I kid around all the time that I have the largest geriatric sports medicine practice in the world. My typical population when I was in Los Angeles and New York, they were younger than me, and I'm 68. Now most of my patients are 68 and above, and they still think they can play competitive sports. You know, so that's what I'm dealing with. So trying to keep them from re-aggravating things is very difficult. But I typically will wait for them to come back to me, you know, but we treat this, I mean, it's a combination of therapies. I mean, Peter didn't tell you, like for his meniscus tear to heal, I put him in an unloader brace to take the initial load off the meniscus. So we're essentially not wringing out that meniscus and squeezing the bioformulation out of the tissue, allowing it to tissue uptake. The rehabilitation process is extremely important. And we found with our ligament work that if we're too aggressive within the first 3 weeks, the chances of our treatment to be a success is minimal. So I hold rehabilitation back, especially in a formal sense. I'll have them do certain things. I'll unload them in different ways. I try not to make them non-weight bearing unless I'm treating the subchondral bone, you know, but I let them present to me back after they load it too much and they create that inflammatory state again before I actually will go back and redo them. Peter, you didn't talk about much. We changed your formulation too. The second time we did this, we did a combination of neutrophil rich and hyaluronic acid the second time. And Ignacio and I, we spoke about this a little bit at ESCA this year in Milan, but I think combining PRP, and I'm a firm believer of combination therapies, you know, so the more severe the treatment, or the more severe the pathology, I think we get a definite benefit from adding bone marrow concentrate for a number of reasons, as well as hyaluronic acid, but that's a different topic altogether. But I think Peter's talk was phenomenal, as it usually is. And you went on time this time too. It was great.
Well,
thank you very much. I think bone marrow maybe for our next topic, because this is really very interesting, and we in Spain don't have as much experience as you have in the States.
No, I leave it up to the president and the international connector of AEMR to well, come up with well, another way to deliver. And we can do the same thing for bone marrow or adipose. Whatever well is needed, we're happy to supply.
Sure.
Thank you.
Okay, Peter, I have a question.
Yes,
In
come
your
on.
in your last paper, Profound Properties of Protein-Rich Concentrate Matrix as a Novel Multi-Purpose Biological Platform in Tissue Regeneration. This is your last paper, very interesting. And you talk about the importance to use platelet-poor plasma and also exosomes and also matrix, like a protein-rich platelet concentrate. So can you talk a little bit about this? What are the difference between those different products?
Yeah, well, the paper is submitted. It's in preprint, but it's not yet accepted. So just keep that in mind.
Okay.
But what we did is the following. We are aware that in platelet-poor plasma, we have very, very valuable growth factors, which we do not have in platelets. Like IGF-1 and hepatocyte growth factor, they are bound to the specific receptors in platelet-poor plasma. That's one. Normally, you discard after PRP preparation procedure, you throw away your PPP.
Yes.
And then what we did, we went back in time on my roller coaster, starting in the 1990s, where we used PPP quite a lot, actually. And we concentrated it. So the PPP...
For which conditions did you use PPP?
We use it as a matrix, right? Because if it becomes activated and you have a high concentration of fibrinogen, it becomes a very dense matrix. So the pores in the matrix are going to be very small. So now what we did, and we already did a bunch of patients so far, is instead of throwing away the PPP, we filter it, take the water out of it. We have a capture rate of more than 90% of alpha-2 microglobulins as well. And we have the level of fibrinogen times 3 to 4, depending on how much water you take out. So we get 2 syringes, one with the PPP concentrated protein rich and 1 syringe with the PRP at a high concentration. You mix them together in 1 syringe, and then depending on what you want to do, 10 tears, partial, full thickness, you add calcium chloride to recalcify your PRP, so it becomes easier for it to clot. We don't use any thrombin, and then you inject it into tissue voids. So when it does, it will set up a clot within seconds. And we have ultrasound images to show that, right?
As a scaffold.
As a scaffold, yes. But so the scaffold turns into a matrix. So we have the concentrated fibrinogen as a scaffold. We mix it with PRP constituents. We have a matrix. We're going to inject it. So the function of the matrix is a bunch, actually. The first one is what a clot does is it attracts invading cells like stem cells and monocytes, macrophages. The fibrinogen has receptors that really attracts these cells. So they're going to be bound to the matrix. That's one.
Homing, like a homing effect.
Yeah. So they stick to the matrix. But inside the matrix is where we also have high concentration of cells. So what's happening now, over time, the body will recognize, hey, there's a clot, and homeostasis takes care of it and starts to liberate tissue plasminogen. And that will eat the clot slowly, slowly, slowly. So you have that clot in place over a period for at least 3 weeks. But it breaks down by...
While tissue regenerates.
While tissue regenerates, and everything that's in there and on there will be released, not with a burst release of PRP, like with PRP, well, within 24 hours, maybe 36, everything is gone. All the, like you've seen on the imaging from the electron microscope, these cells are empty. But now it releases its content for 2 to 3 weeks. So you keep on stimulating that area for a long period of time. That's what we call the sustained release phenomena. But not only that, we add, especially for tendons, IGF-1 growth factor to it. And IGF-1 is one of the most important growth factors for tenocyte proliferation. So depending on where you deposit the matrix, you inject the matrix, you have many more functions as a matrix. And that was the goal of the paper. And we just have seen, Luga and I, this week, a couple of patients we did. And you still can see the clot even after 8 days, 10 days. It's still there. While the patient is still...
By ultrasound?
Yes. So you see the clot, but look, I'll let you tell him the lady with the pelvic fracture. How she came.
Patient came in to me that she had it was going on to either delayed union or non-union of superior pubic ramus fracture. So I was kind of perplexed on what to do for this. I was going to probably put a bone stimulator on her to try to get this to heal and try to do a combination of platelets, bone marrow, whatever we can do to try to stimulate that healing. So Peter and I discussed this. We decided to do a combination of platelets, bone marrow, and this protein matrix. She could barely walk when she came in. She was on a walker, very painful. We did the procedure under ultrasound guidance in the office. We were able to get into the fracture site with the needle, deposit the graft, and then above the graft, we laid the matrix above it. And we're able to see exactly where this was and where it, basically how it covered the bone. I sent her home. We kept her on her walker. Exactly a week later, she came back in for reevaluation. We ultrasounded her. One thing, she was almost pain-free, which was surprising to both of us. We ultrasounded it again and looked, and the matrix was still in place. But her response was significant. I saw her actually yesterday when her husband came in for biologic treatment of his hip osteoarthritis, and she was even in less pain than I had seen her a week prior to that. The other case we had was an adult baseball player who works for the Red Sox organization, who had a osteoarthritis in his glenohumeral joint, his AC joint, and had high-grade partial tears of his supraspinatus and subscapularis and biceps tendon. We put the same construct into all of those. We put platelet, bone marrow, hyaluronic acid into the joints, and we put the matrix construct with the bone marrow and the platelets into the tendons. Same thing, came back a week later because I see these back in a week. We re-ultrasounded it. Again, he was pain-free. His motion had improved significantly. No more night pain. He could sleep on his shoulder at night. Didn't awaken him any longer. His motion had improved, and the matrix was still intact. And this is the third one we've done. He was the third one we've done. And all three of them have done substantially well. And this has really opened my eyes to this. And now with my tendon work particularly, and possibly some of my ligament work in throwing athletes, I think I'm going to adopt this for these on a more permanent basis, because I think this, from a short N of three, these have significantly changed these outcomes short term. So we're looking at this pretty closely as we go on and see how this pans out. But I don't think this is going to get any worse. I think this is going to get better as time goes on. And I'm sure you agree with that, Peter.
Oh, yeah.
Okay, thank you very much. We have two more questions. Yeah, it's a little late. Doctora Juliana Mendoza, she asked about what is your opinion about the role of the peripheral nerves in this bone joint brain dialogue and its signaling for healing. In other words, peripheral neurolysis of geniculate nerves could have some positive or negative effects as combined treatment with regenerative medicine techniques?
Yeah, that's I saw it in the chat, Thank you, Dr. Mendoza, for the question. That's a very interesting thought on how we actively, can or cannot stimulate peripheral nerves. I mean, the nerves are there for a reason, and we know for 40% of patients that have pain following osteoarthritis, it has nothing to do with the joint. It has to do with the nerves and the chronic inflammation of the nerves. So yeah, that's an area that has a particular interest for us as well, because of all the important work that has been done on, well, how we can, influence neuropathic pain, right? And if we can influence neuropathic pain from a different perspective than from the traditional perspective in patients with, for example, diabetes, which respond tremendously well to a high-dose leukocyte-rich PRP, then maybe apart from addressing intra-articular or subchondral bone or any other structural tissues in the knee, the emphasis, it should be, maybe directed as well to peripheral nerves. Long story short, I don't know the answer, but I think the way to address it would be very, very interesting. Thank you for the question.
Okay. Here with us is Dr. Anssar, is the director of the British Academy. I would like to say hello. Dr. Anssar, are you here with us? Nice to see you.
Hey, I'm sitting in a car, so that's why I kept my camera off.
Thanks
I'm
for
not
coming.
driving, don't worry. You're welcome. Great talk, Peter.
Thank you, Anssar.
Thanks for your input.
Do you want to say anything about this conference?
No, it's Britain's probably first international level regenerative medicine focused conference. It's we have a couple of parallel themes that we're doing: plastic surgery, aesthetics, dermatology in one parallel hall, and we're doing MSK pain management, men's, women's health and longevity in the other one. So it's quite a broad conference, but one of the halls is very MSK pain focused, with some other very interesting speakers around cardiology, stem cells, where some of the new pioneering research in heart failure and post-MI has happened in the UK. So yeah, it's a really diverse conference, but with about 80% focus on MSK and pain in one hall, and skin, wound and plastics regeneration in the other hall, followed by a course similar to the courses I suspect you run around BMA, adipose derived and PRP. So looking forward to having some of you guys coming and some fantastic conversations. The matrix, I'm using a matrix in the UK, Peter, but I actually use heated PPP, which denatures the proteins and gives me a matrix in which I can embed my PRP. And it's for the same principle. It's a slow release effect that we're trying to achieve. And I've also seen some really interesting results. But when you combine PRP with BMAC, we know it has quite a potent effect on nociception. So the pain fibers usually respond quite potently to that combination. So I don't know whether that's a matrix effect or whether that's just the BMA with PRP. So we've seen that with BMA and PRP before, where pain improves far before you're expecting, healing or regeneration, but the pain starts to diminish quite quickly. So just wanted your thoughts on your method of making the matrix and my simpler method, which is probably just heated PPP to denature it, and then I mix that up with the PRP. And as Luga has said, when I scan them a week later, you can see it. But when I scan them 2 or 3 weeks down the line, I can't really see the matrix anymore. So I know it integrates completely and disappears. But thank you, great talk, and thanks for everyone's time.
Thank you. No,
Thank you, Anssar.
Thank
See
you,
you soon
Anssar.
in London.
See you soon. Bye-bye.
Thanks, guys. Looking forward.
Okay. And the last question, Dr. Everts, Peter, we are increasingly selective with treatments, dosage, types of orthobiologics or multidimensional treatment. And then my question is, there is no place for surgery anymore?
There's always gonna be a place for surgery, for sure. So nobody should be afraid. The challenge is in finding the collaboration between non-surgical and surgical. At some stage, patient with severe OA, if it's end stage, nothing is going to work, right? Then the knee needs to be replaced. But the clue really is, especially in, well, orthopedic surgical centers, is to be on track with patients very early. And that's where the synergy really can develop between non-surgical and surgical under the same roof. And that's what I see happening here right now, more and more. So you have easy access to patients because you're going to treat them, and all of a sudden the surgery is still needed. And in a lot of cases, well, keep in mind, PRP and bone marrow, it's not the holy grail, right? It's not something that will cure everything. And sometimes patients, are not compliant to post-treatment plans as well, and will get into more, pathological conditions than they came in before. But I think if we can find each other in see the lights of day as a non-surgical interventionist and an orthopedic surgeon, I think the patients are only going to win, and they're going to love you to death.
I agree.
Okay. Anybody want to say anything? Or I think it's 10:30 in Spain. It's late.
Yes, we can talk hours and hours because we all here are very passionate about this topic. But I am thinking about your presentation, Peter, was very, very complete, from basic science to systematic approach. But regarding doses, do you think we will still talking about platelet dosing, or the future will be more complex regarding different type of molecules that are in it?
Yeah, no, a fair point, Ignacio, and I believe you and we talked about it quite some time, but dosing is one. Let me start with that. But the concentration is also important, right? You can have a dose of 5 million in 3 mLs or in 10 mLs. The dose is going to be the same, right? What for platelets is important is the high concentration. So platelets prefer a lower volume in order to have the proliferative work done. So if you have 5 billion in a syringe, you can give 3 mLs or you can give 6 mLs, right?
Okay, but
So
you mean high dose means 1 billion per ml?
Yeah, but if you want to do a joint and inject 10 billion,
10 ml.
you can do 10 ml, but you also can do 5 ml. It all depends on your preparation methods and the ability to concentrate more. So concentration and volume defines the dose. But individually, a higher volume of platelets is less effective than the lower volume. I mean, we know that for 20 years now, that the proliferation and the differentiation of platelets is better done at higher concentrations than at lower concentrations. So there is always a tension field between concentration and volume that we need to understand. To your second part of your question, I think it's going to be very interesting to see with added modalities, whether it's, implementing plasma-based growth factors, which we normally just throw away, right? Because we don't think we have a need for them, and I tell you, we do have a need for them. I'm lecturing in 2 weeks in Harvard. I do a course, teaching in a course on pain management and orthopedic procedures, only using biologics, PRP and stem cells. So next time I can tell you more about, what Anssar also mentioned is the nociceptive effects, because it's way more complicated than we think. We have direct effects, direct molecular effects, and we have indirect tissue repair conditions, right? Like angiogenesis, how to build tissues, immune modulation. We can think of many different ways that have an impact on pain. So that will be very specific. And then, depending on, the capabilities of PRP devices, in a lot of cases, you maybe want to have a monocyte-rich PRP, right? Because we recognize the value of monocytes and their polarization. I'm pretty sure,
monocytes is not the same that leukocytes.
No, monocyte is one of the leukocytes.
Exactly, because you show in your fourth syringe that in one syringe you have high quantity of monocytes, but in the other, high quantity of leukocytes that are different.
Neutrophils, you mean?
Neutrophils, yes.
Yeah, it all becomes on the density, right? So the monocytes are, their density is less than for the neutrophils. So if you have two-spin centrifugation, the concentration of individual cells is way more profound than with a single spin. So with a single spin, platelets can be all over the place, and they are all over the place, actually. So when you start to concentrate them based on their densities, you also can imagine that when we have more, well, sophisticated extraction techniques, really can capture, and which we already do. I mean, the monocytes, with the procedures we work with, our trials with Luga, our increase in monocytes is 15 to 20x. It's higher than with platelets. Based on understand.
Do you think that leukocytes induce inflammation?
They will induce inflammation, but that's what they need to do as well. So if you cut your finger, you will have inflammation, and after that, the wound is healed, right?
But inflammation means pain or just healing cascade?
Stiffness. Yeah, it's part of the healing cascade. And what Luga mentioned after my maintenance dose, I said, no, listen, let's do leukocyte rich intra-articular instead of leukocyte poor. And you know what happened? You only have a stiff knee. You have a stiff knee for 72 hours, and after 72 hours it gets better, and 6 days later, everything is gone. But what we do not understand is that neutrophils polarize as well. There is neutrophil polarization, and different types of neutrophils have different function. Yes, they create inflammation, but it's transient. And the big difference is, I cannot emphasize that enough, is we have acute inflammation and we have chronic inflammation. Neutrophils in your PRP do not create chronic inflammation. They create a transient inflammation to go to the next phase in healing. So if neutrophils would create chronic inflammation like you have with chronic osteoarthritis, that would be a very bad thing to do. But it's only very temporarily. It only takes 72 hours. And then the healing effects of neutrophils start to kick in. And you know what? If you prepare your patients, hey, listen, this is what we injected, right? And you know what's going to happen? You're going to have a stiff knee for 2, 3, maybe 4 days. But after a week, it's all gone. You won't feel anything. So it's all about perception and how you, well, prepare your patient as well. That's what can happen. Luga, help me.
Absolutely. Well said. I'll tell patients when I do this, and I see it more in soft tissue than I do in the joint. But like if I treat soft tissue, oh, it hurts. And I tell them, listen, you're going to hate my guts by 4 hours from now. But I treat them a little differently too. I put heat on them immediately, and the heat dissipates the pain almost immediately, and Peter can attest to that.
Absolutely.
And at first I was using ice, but if you think of what ice does and cold does, I mean, it stops blood flow, it stops neurotransmission, which is the opposite of what you really want. You want blood flow in the area. You want the muscles and the tendons and the joint to normally function. So the heat actually does this very well, and it absolutely reduces the pain. And I have them do this for as long as they will possibly do it, but I have them do it several times a day for 15 minutes at a time, and then have it stopped a couple of weeks down the road if they want to continue to do it. But their responses are significant, and you don't see this prolonged, painful response that people think they're going to get.
Well, perfect.
Okay. I think Dr. Everts, it's been a long time.
Charla sobre platelet, porque es en inglés.
Sorry? And thank you very much for your conference. Long time since I heard such a novel and disruptive presentation, contribution, so many news, and with publication by the same actor. It's very, very appreciated for me. You have left the list on very high for following webinars.
Gracias por tu conferencia. Está terminando, pero
Tu esposo tomó una esposa.
este es español.
Haré que te hagan un vestido. Tengo una costurera maravillosa.
1 second. Okay, sorry.
You're good.
Thanks to all the assistants, thanks to the DEBA group, and I would like you to say your last word, Dr. Peter, or finish the conference, please.
Well, first of all, I'm very pleased with your invitation to speak to your new academy. You have I think you started at the right time. You looked to the left and to the right what was going on, and I'm pretty sure your team, including Ignacio, you know exactly where you want to be. You know exactly how to get there, and the only thing I can tell you is whatever I can do, Peter at goldcoastbiologics.com, or Dr. Luga, reach out to us. We would be more than happy to help any of your members, getting to a fast learning curve instead of, making the same mistakes that we did as well, right? I mean, the roller coaster was a roller coaster, and I only was proud to show you the highs, not the lows, right? So we also made mistakes, and we learned from it, and we feel with more people getting interested in doing the right thing for their patients, you will have both of us, if I may say, for Luga as well, on your side, and shorten your learning curve, and create a good start for your patients, for the society, and we wish you all the best. Thank you.
Thank you very much, Dr. Everts. Thank you, Dr.
Thank
Dallo.
you, Peter.
Thank you, Dr. Luga, all the assistants.
Thank you for having us.
And see you then in the second webinar with Dr. Alicia Ronaldi on 20th of June of this month. And it's a really pleasure to me to stay with all of you. This webinar is recording. I will send you the link, and Dr. Gonzalo Mora will do a brief resume about all your fantastic conference, Dr. Everts. Thank you very much, and see you very soon.
See you soon.
Bye-bye.
Thank you.
Dr.
Bye-bye, everybody.
Gracias.
Thank you.
Adiós a
Gracias.
todos.
Bye,
Gracias.
Ignacio. Take care.
See you.
Adiós.
Adiós.